All right, this morning we have Dr. Wayne Wirt with us. He doesn't really need an introduction for those of you who have been here before. He's always does such a great job. But his first new drugs update was 94, I think is what Mandy told me, and was down in Orlando. And it seems like it's been a long time ago. And he's done it ever since then. We had a little gap here for a year or so, and he's back today. And he's been doing this for, I guess, 20 years now, basically off and on, or mostly on. And we appreciate those years of updates. Now, correct me if I'm wrong, but you're professor of the Department of Clinical Pharmacology and Outcome Sciences in the South Carolina College of Pharmacy. He has a PharmD degree, and let's see, professor of family medicine in the College of Medicine at the Medical University of South Carolina. Yep. And he has got a great presentation for us this morning, always entertaining. And let me just turn it over to Dr. Wirt.
Thank you, sir.
You're very welcome.
It's a pleasure to be here. What I'd like to do this morning is to kind of update you on a lot of new things that are happening when it comes to pharmacotherapy, drug therapy. And this is likely to be a record year. We are on pace for having more than 50 new drugs approved by the FDA this year, 50. And it is amazing to see what's happening. One of the problems, as you see as we go through some of the new drugs, is can we afford them? That's the real question. And if you go back 4 years ago and look at new data that was just released in last month from InPharma, and it's just looking at the pharmaceutical industry in the U.S., the average revenue per drug 4 years ago was about $1,200 per drug in 1 year for patients who were on the drug. And that drug served an average of 690,000 patients. The average number of people that would benefit from that drug, 690,000. Well, this year the data suggests the average revenue per drug is over $9,000 per drug. So it's gone up eightfold. And the number of patients benefited is 160,000 instead of 690,000. It tells us where the pharmaceutical industry is going to today. They are moving towards specialty products, the high-end biotech drugs that have price tags that go through the roof, and the number of patients that benefit are smaller targeted areas. That's where the industry is going, and that is a telltale change in the last 4 years. It is very, very palpable. So that's going to be reflected in a lot of the things. And we're not going to talk about a lot of the specialty drugs today. I'm going to focus on the primary care drugs, since that's what we're about. But if you look at the oncology products, the specialty products in multiple sclerosis, for rheumatoid arthritis, where the industry is going with the high-tech, high-cost drugs, those drugs are coming at a much faster rate because the pharmaceutical industry is able to identify targets, go after those targets that are genetic targets a lot of times, and it takes less time, fewer patients, and you can target them much more cost effectively from their standpoint, and then bring out a drug that, while it may have less utilization, we can put a high price tag on, and our return on investment is returned much faster. So we'll give you the most successful pharmaceutical drug in the history of the industry that was approved this year as well. We do have it in the handout. So we're going to do a new drug update. There's lots of stuff to talk about. I don't have anything to disclose. I don't speak for pharmaceutical companies, haven't in the last 4 years, and I no longer do any consulting for pharmaceutical companies. So no disclosures. What I want to start with is a little bit of an update on immunizations. And this is also a rapidly changing field, and there are lots of new things in the last 2 years that are important to us in primary care. So one of the things that was changed is the pneumococcal vaccines. We still have 2 pneumococcal vaccines. We have Pneumovax 23, which is a polysaccharide vaccine with 23 different strains of the pneumococcus covered. And we also have Prevnar 13, which is a conjugate vaccine. And it is only 13 strains. And there's good cross-coverage between them. In fact, I believe that the Prevnar 13 only has 1 or 2 strains that are not in the Pneumovax 23 vaccine, but they tend to be strains that are increasing in prevalence since they weren't covered in the old Prevnar 7 or in the Pneumovax 23, and some of those were drug-resistant, including penicillin-resistant strep pneumo. So that's one of the reasons we have the 2 vaccines. But the other major reason is the polysaccharide vaccine, Pneumovax, is not immunogenic in children, and it's probably not as immunogenic in the elderly as the conjugated vaccine. So when you conjugate the vaccine, you increase its immunogenicity. So that's why we use the Prevnar in kids, and now we also have Prevnar for adults. Started back in 2011 in December, the FDA approved Prevnar 13 for adults age 50 and older. But it was based on immunogenicity studies, no outcomes. And the CDC Advisory Committee, the ACIP, did not make any recommendations about using Prevnar in adults until this year. And I'll show you the data why. But that was the first time it was approved in the label. And a couple of things when it comes to vaccines. There are 3 different processes that all have to come together before a vaccine is routinely recommended for us to administer to our patients. First, it has to be an FDA-approved vaccine, unless it's under protocol. But that doesn't mean it's recommended. This vaccine was approved and on the market for adults in December of 2011. It was not recommended for us to administer to adults, older adults, until last month or September of this year. So there was a time lag. First thing that typically happens is the Advisory Committee on Immunization Practices, ACIP, of the CDC meets, reviews the data, and makes a recommendation to the CDC whether we should use this vaccine or not. Then the CDC has to decide to follow the recommendations of the Advisory Committee, and it's not official until it's published in the MMWR, Morbidity and Mortality Weekly Report, the official CDC publication. Then it's a recommendation from the CDC. So all 3 things have to happen before it's going to be a covered and recommended vaccine. So this was the first piece, but it wasn't recommended. In June of last year, the FDA Advisory Committee recommended that this vaccine should be given to high-risk patients in addition to Pneumovax 23. So you get both vaccines if you have AIDS, cancer, organ transplants, advanced kidney disease, other immune-weakening conditions, your kids with sickle cell disease who autosplenectomize, those people all were candidates for both vaccines. That was the recommendation as a vote of 14-0 back in June a year ago. Well, it was actually recommended by the CDC last October. So October of 2012, it was recommended that these patients get both vaccines. But what was interesting, if you have say a 20-year-old with sickle cell disease and they've not had both vaccines, if they've not had either vaccine and they should have had the conjugate vaccine, but they haven't, you get the conjugated vaccine first because it's more immunogenic. And then if you need to give the second vaccine based on these new guidelines, you have to wait at least 8 weeks after your dose of the conjugated vaccine to give the polysaccharide vaccine. That's the recommendation by the CDC at least 8 weeks later. So this is from MMWR. On the other hand, if the patient has already had the Pneumovax 23, you have to wait at least 1 year to give the conjugated vaccine. There has to be at least a year between the doses if they've had the polysaccharide first till you give the conjugated vaccine. Okay, this is the CDC recommendation. So that's where it was October 2 years ago. This is the trial that's now been published. It's called the CAPiTA trial. And the CAPiTA trial looks at the conjugated vaccine in adults 65 and older. And what they did, they followed these people for 2 years looking at their risk of developing pneumonia, including community-acquired pneumonia and invasive pneumococcal disease. And what they found is vaccine-type community-acquired pneumonia was reduced by more than 45% in these adults who got the new vaccine, the Prevnar 13, at age 65. And invasive pneumococcal disease was 75% reduced if they got the vaccine. So this is the data the ACIP reviewed this summer. And they made a recommendation to the CDC that this vaccine be routine for all adults 65 and older as well. So now we have the CDC on September the 19th of this year has recommended both vaccines for patients 65 and older. And typically we've been giving Pneumovax at age 65 as long as it's been at least 5 years since they had their previous dose. So right now, if you had that 20-year-old who had sickle cell disease, if they were to live to age 65, they could get 3 doses of Pneumovax. They get 1 dose at age 20. They get a second dose 5 years after the first. And then they get a third dose when they get to age 65. So that's the max number of doses of Pneumovax you can give in a lifetime right now based on the guidelines for high-risk patients. They also would have gotten Prevnar 13 as a child, and there's no booster there, but when they get to age 65, they now get a dose of Prevnar 13. And nobody's going to be in that category right now because Prevnar 13 or Prevnar 7 hadn't been around that long. So we're not going to have that scenario right now. But when you give this, they also recommend at age 65 you give the Prevnar first. And then you wait average of 6 to 12 months, not 8 weeks, to give your dose of the polysaccharide Pneumovax. And if they've had Pneumovax first, as I have, you have to wait again at least a year before you give the conjugated vaccine. It's getting more and more confusing, and the good news is this is on the CDC website, and the vaccine schedules include this in them now, updated September of this year. So that's the conjugated vaccine, and again, we've got that. This is the other wrinkle in the thing. Right now, Medicare pays for 1 pneumococcal vaccine for people 65 and older. And a representative of CMS was at the ACIP meeting where they recommended both vaccines. And that person was on record as saying, Medicare right now will only cover 1 pneumococcal vaccine in your lifetime. The recommendation is we now get 2. And that representative said, unless we can change something, the first time Medicare or CMS can address the coverage issue is January of 2016. Which means until January of 2016, if you get both vaccines, one of the 2 is on you. There's no Medicare coverage for both vaccines right now. So that's something you need to talk about with your representatives, your senators, because they need to do something about that. And it turns out Pneumovax is less expensive than Prevnar, but in my case, I've already had Pneumovax covered under my Medicare coverage, so I have to pay out of pocket to get my Prevnar 13 at least a year after I got my Pneumovax 23. So that's the termite in the woodpile with coverage right now for your patients. So lots of little things going on, but this is a huge issue, and it's something we need to pay attention to and be aware of so that we can educate our patients what they need to do and why, and what the coverage issue is right now. Questions on the pneumococcal vaccines? Yes, sir.
Do you have any problems with the patients getting injections in pharmacies all over the place? And secondly, what is the cost of that particular one you're talking about?
Okay, the cost of, you can see the Prevnar 13 is $135 to $150 out-of-pocket cost to buy the vaccine. Okay, so it's more than the Pneumovax, not a whole lot more, but it's on the higher end. And pharmacies right now, depending on the state, up to the state, and in South Carolina we have a protocol, but the protocol is by the South Carolina Board of Medical Examiners that allows pharmacists to administer the flu vaccine without a prescription to adults. We can only administer these vaccines with a physician's prescription in South Carolina. Our protocol does not include the pneumococcal vaccine. Some states it does. So it depends on your state whether you have a protocol for your pharmacist to do that. And when it comes to some vaccines like Zostavax, Zostavax is covered under Medicare Part D, which is reimbursed through pharmacies, and you may not be able to get it unless you have a plan that links it. So again, the reimbursement sometimes also dictates where the patient's going to get the vaccine. And those are all different from state to state depending on your laws, as well as the federal reimbursement. Because these guys are not covered under Medicare D, they're covered under Part B. So it depends on, the coverage is different depending on the vaccine with the federal government again. Not an easy thing to keep track of. Flu vaccines for this year. This is also a moving target. And the good news is this year's flu vaccine is the same as last year's as far as coverage. They have 2 A strains and 1 B strain in all the vaccines. And now, as of last year, we had about half the vaccines were quadrivalent. Same 2 A strains in all vaccines, 1 B strains in common with all vaccines, and then a second B strain in the quadrivalent vaccines. And that's true for this year again. And many of the vaccines last year that were trivalent are now quadrivalent. There's no recommendation by the CDC to prefer one over the other. But right now, they're all equally recommended. So that's the strains that are in it. Now, last year, FluMist was the only one that every dose you got was quadrivalent. That's true this year. So the live attenuated nasal flu vaccine is quadrivalent. And it's live cold attenuated. And it's FDA approved ages 2 through 49. And in patients who don't have immunosuppression, that don't have lots of risk factors, that don't have asthma. Okay, so those are the patients that you can use FluMist in. I'll come back to that in a minute, because there is now a group that FluMist is a preferred vaccine for the first time this year in the new guidelines. The quadrivalent injectables, and the only one that goes down to 6 months of age, which is a recommended starting dose for influenza vaccine, is the one from Sanofi Aventis, and that's the one that's listed, the Fluzone. That's the only one that goes down to 6 months of age. All the others are age 2 or 3 or above, some just for adults.
Do they contain mercury?
The question is, it contain mercury, thimerosal, which is a preservative, only in the multi-dose vials. None of the single-dose vials, none of the pre-filled ones have any thimerosal preservative in it. It's only the multi-dose vials that have thimerosal. And that's a huge conundrum, because there are a lot of people out there still mistakenly think that's the association with autism. And there is no cause and effect. According to the Institute of Medicine, the CDC, the American Academy of Family Physicians, the American Academy of Pediatrics have all looked at the data. They see no association. And the original study in Lancet was withdrawn as made-up data that led us to that conclusion. So we're not really believing that's the case, but there's still a huge number of folks out there that use this as an excuse not to get their children immunized. And the single doses have no thimerosal mercury in them. We have 2 new ones last year. Cell culture based, which is by Novartis, and it's made in dog canine kidney cells, Flucelvax, and it's FDA approved ages 18 and older. There is no data currently in patients less than 18. So it's not for kids at this point in time. It's being studied, don't have the data. And then also last year, for the first time, we have a recombinant DNA product, and that one is Flublok, and it's actually manufactured in the fall armyworm. And both of these technologies are used for other vaccines. This is the first time they've been used for flu vaccine. And the CDC and the FDA are encouraged by having these technologies available, because it's not based on egg cell culture, and they're more readily scalable so you can produce the vaccine faster with these technologies. So if we have, and it's only a matter of time, when we have the swine flu type thing again, where we may have to have another vaccine produced because of what we see, you remember we had a deficiency or a shortage of the original vaccine, and it took a while of delay to get the new vaccine out. A couple of years ago when we needed both vaccines. This should provide for a faster response, and that's one of the reasons they got priority review at the FDA. But right now, it's the same strains, they're the same, just made in a different way. And the one thing I'll tell you about Flublok, and it was actually changed this past week. It was 18 to 49. The 49 is no longer the upper age limit. It's now anybody, including those of us over 65. So that was a change for Flublok in the last week. So the labeling and the CDC have changed that, and it's in the slide correct, 18 and older. Used to be 18 to 49. And Flublok is the only vaccine that has no trace of egg protein anywhere in the vaccine. So it's the only one with no egg component at all. But again, it's not approved for kids. It's being studied. And the other caveat you got to remember with Flublok, it's got a very, very short expiration date. 12 weeks after it's produced, it expires. So you got to keep looking at the expiration date on Flublok. All the other vaccines, if they're stored appropriately, have the same expiration date. June the 30th of 2015 is the expiration date on every other flu vaccine you have that you've gotten this year. They have a universal expiration date, June the 30th of the following year after they're produced. The exception is Flublok, 12 weeks. Okay, so, and it's more expensive, so be careful, look at the expiration dates, with Flublok in particular. These are the other ones that are trivalent or quadrivalent, and you see the age ranges are here. The age ranges are based on what was submitted to the FDA from their clinical trials for approval. So that's why there is a different age range for each vaccine. Depends on the study data presented to the FDA. Like I said, the only one that goes down to 6 months is Fluzone by Sanofi. If you look down towards the bottom, you have Fluzone high dose, which right now is still trivalent. And it's for 65 and older. And it's 4 times more concentrated than the regular flu vaccine with the 3 different antigens in it. And it's for people 65 and older. We don't have a recommendation, but I do have a new study I'll share with you in a minute. And then the Fluzone intradermal is still also trivalent this year, and it is a smaller amount and a much shorter needle. But again, it's not recommended as preferred for any patient population. So this is the data on FluMist. The ACIP this past year recommended FluMist be preferred in children ages 2 through 8. 2 through 8 as preferred flu vaccine based on 3 trials that show a 32 to 55% better efficacy than the same vaccine injectable. Okay? So children ages 2 through 8 who don't have asthma, who are not immunocompromised, that don't have sickle cell disease, is a preferred vaccine this year for the first time ever because of increased efficacy. So that's the recommendation. But if you don't have the FluMist and you do have the injectable flu vaccine, go ahead and use the injectable vaccine as the CDC's recommendation. And if I was a pediatrician, I would only stock Fluzone or FluMist, because Fluzone's the only one I can still give between 6 months of age and less than 2. I got to use the injectable vaccine, and it's the only one approved less than 2 years of age. So that's the one I've got to use in pediatrics for ages 6 months to less than 2. And at age 2, the recommendation for most kids is FluMist for the first time. So that's new this September. Healthy children aged 2 through 8 who have no contraindications. Now, we also have data suggesting that we need to avoid it in those kids 2 to 4 if they have asthma. Even if they have not had an exacerbation, if they have a history of asthma, probably avoid it from ages 2 to 4. There's a study in the CDC recommendations if you're 5 to 17 years of age, where they compared FluMist to injectable flu vaccine in kids with asthma and found no difference. So if you've got a patient who's stable, is doing well, they're not having exacerbations of their asthma at age 5 and above, you could consider still using FluMist, and that's talked about in the guidelines, but is not a preferred regimen. It's only for kids who don't have asthma or not immunocompromised. And if you have a child that you're going to give FluMist to, and they're exposed to influenza, you give them the FluMist, and then you decide to give them prophylactic oseltamivir, Tamiflu, because they've been exposed, the FluMist doesn't work. So the antiviral therapy inhibits FluMist from working. It does not inhibit the injectable vaccine, the killed vaccine, from working. So there's no contraindication. You're still going to see the effect if you give the injectable vaccine, but if you give the live vaccine, you cannot also treat with an antiviral. If you do, the vaccine you gave is not going to work. Okay, does that make sense? So the recommendation here is, again, if they've taken an antiviral within 48 hours, you don't give them the FluMist. So you have to wait after they've completed the course of the antiviral therapy to give them the FluMist. Not the case with the injectable vaccines. You can give the Fluzone at the same time. You treat them with oseltamivir or Relenza. Doesn't matter, okay? But it does with FluMist, so that's on here. If you got egg allergy, this changed 3 years ago and it's changing again. Right now, they say if you have somebody with egg allergy, you can give the injectable vaccine even though it's produced in egg cell culture, because there's only minimal amounts of egg protein in the vaccine. And they've done that for 3 years before we had the Flublok that had no egg protein in it, and we weren't seeing an increased risk of allergic reactions. The only thing it says is do it in the office of somebody who could treat anaphylaxis should and if it occur. Don't get it in the grocery store. Don't get your flu vaccine at the pharmacy. Get it in the office of somebody who can treat anaphylaxis should and if it occur. And they've done that, and it looks like it's safe. Now we have, for severe egg allergy or somebody who's not going to get the vaccine, Flublok is a recommended alternative because no egg protein anywhere in the production process. Turns out Flucelvax, the animal cell kidney culture, still was used. The original vaccine strain was from egg cell culture, not the case for Flublok. So that's the only one that has no possibility of cross-reactivity with egg allergy at all. But it's more expensive and a shorter shelf life. So that's on here. That was also an MMWR this August. This is the data that has been discussed but has not yet been included in the guidelines. This is a study that Sanofi did comparing the high-dose flu vaccine versus regular flu vaccine over 2 years from the U.S. and Canada, over 32,000 patients. And the FDA said, in order to get a claim in your label that's superior, you have to have a 9 to 10% better efficacy rate with the high dose versus regular Fluzone. So they did the study, it's now been presented. It was 24% more effective. So it met the FDA's criteria, so we anticipate the label will change to say that the high dose for people 65 and older is significantly better than regular flu vaccine. Problem is, look at the numbers down here at the bottom. So if we look at the high dose, 1.43% was the confirmed, laboratory confirmed rate of influenza over that 2 years versus 1.89%. So it's 24% relative difference, but the absolute difference is 0.46 of 1%, less than 0.5%. So you convert that to a number needed to treat. Number needed to treat, 218. So for every 218 adults, 65 and older, who get the high dose versus regular flu vaccine, you have one less laboratory confirmed case of influenza. That's the data. Different way to look at it. It's 24% better, but the absolute benefit is less than 1/2 of 1%. So again, if you've got the high dose, and it does cost a little bit more, then go ahead and use it, because there was no increase in adverse events in this study with high doses versus regular Fluzone. But if you don't, you're still better off going ahead and getting regular Fluzone rather than delaying getting the vaccine according to the recommendations. So we don't have a recommendation to prefer one over the other, but this is the data. So again, you can make that decision along with your patient depending on what vaccine you have available at the time. Okay? So this is yet to be addressed by the ACIP. Another thing happened in the last week. Meningitis type B vaccine. We've not had a vaccine until last week in the U.S. for meningitis type B. And we've had 3 major college outbreaks of meningitis B in the last 2 years in this country. The mortality rate's about 10%, but a much higher rate of neurologic sequelae from meningitis, Neisseria meningitis type B, not covered in the Menactra or the conjugate vaccine that we have out right now. So it covers meningitis, but not type B. So we now have 2 FDA pending, 1 approved, 1 yet to be approved, meningitis type B vaccines, and no recommendations from the CDC. So Bexsero is Novartis's, and it's been approved in Canada, in Europe, and in Australia. It is still pending approval in the U.S. This one was not approved this week yet, but it's got breakthrough status at the FDA, and we expect it to be approved any day now. So we will probably have 2. Bexsero has 4 different mechanisms to target Neisseria meningitis type B, and the other one that was approved this week by Wyeth Pfizer only has 1 mechanism to induce immunity. So these are the ones, a single component was actually approved, both were granted, but 3 days ago the FDA approved Pfizer's monocomponent vaccine, Trumembra. I don't know how they're supposed to pronounce it, but that's what's listed. And it is a meningococcal type B vaccine. FDA approved for ages 10 through 25 based on the study submitted to the FDA, and it's a 3-dose series, 0, 2, and 6-month schedule. Half cc, pre-filled syringe, and the ACIP has not yet made a recommendation on this vaccine. But it is now FDA approved and should be available in the next couple of weeks. So this one's been approved. And efficacy in 3 randomized controlled trials, US and Europe, about 82% efficacy versus about less than 1% as far as looking at the immune response. And this is the immune response is what they're basing these approvals on for these vaccines. And most common side effects, you can see here, it's pretty high side effect profile. 85% or more have pain at the injection site, fatigue 40% or more, headache greater than equal to 35%, muscle pain 30, and chills greater than equal to 15%. So it does have a higher side effect than most of the vaccines that we routinely give. And there's no recommendation right now to give it. Would not surprise me that certain colleges will begin to require it because of the 3 outbreaks that have happened on U.S. college campuses in the last 2 years. And it turns out these vaccines have been made available under CDC protocol on those college campuses in all 3 of those outbreaks. So the CDC did have a protocol to give these vaccines when they've had an outbreak of meningitis type B on college campuses, because it's been in the pipeline for a couple of years. It's available in Canada, the UK, and Australia. So these are the meningococcal vaccines. So stay tuned. We'll see what the recommendations, if any, are. Questions on vaccines. That's kind of a quick update on a lot of the new stuff that's very new when it comes to vaccines. Anybody have any questions related to vaccines?
If you have a question, if you could move to the microphone in the middle so that our
okay, and I'll try and repeat it as well, but please
participants or repeat it.
Did you have a question, sir?
I just wonder if they're effective when you give them in the middle of a meningitis outbreak. Does the vaccine work right away?
The question was, how effective are they in the middle of a meningitis outbreak? It turns out the CDC is looking at that, and that's one of the reasons they did these made them available, but it looks like within a couple of weeks after you have it, you have a significant immune response. And again, they're still using the other chemo prophylaxis, all the other things on the campuses, but it is a problem because the outcomes are so bad. That's the reason they're doing it, okay? But that's the reason most colleges now require you to make sure you've had the meningococcal vaccine, the conjugate vaccine, but does not cover type B. That's why these vaccines have been recommended for approval with breakthrough status. Okay? Let me move on, and this is a topic I think you've talked about a little bit already during your meeting with controlled substances, opioids. Number one prescribed drug in the United States for the last 10 years plus is hydrocodone acetaminophen. Look at the number of prescriptions in 2012, and these are in millions. Over 135 million prescriptions in 2012 for hydrocodone acetaminophen. That fixed combination, that's the Loratabs, the Vicodins, the Norcos, those guys. Number one drug by far. And that's why 2 years ago, the FDA and the Director of Health and Human Services suggested we might want to reschedule this to a Schedule II drug. And that actually happened as of October the 6th, last month. So all hydrocodone products are Schedule II as of this October. Now, prior to that, you could refill up to 5 times in most states. Some states had already moved hydrocodone acetaminophen to Schedule II, like New York had. It was up to the states. You could be more restricted than the federal government. You can't be less. So now the federal government has moved everybody to Schedule II. No refills, no phone calls in. But if you had a valid prescription written before October the 6th, you can still honor those refills depending on what your state allows you to do and what the plan that covers the patient allows you to do. So anybody who had a prescription for Loratab or Vicodin before October the 6th and had refills, up to 5 refills, 6 months, those can still be honored up until April the 8th if it was written on October the 5th. Okay? Anything October the 6th thereafter, no refills. The only way to give more than a 1 month supply is to write 3 different prescriptions on the same day, all dated and signed the same day. But on prescription 2, it says do not fill before 30 days after the first one's written. On prescription 3, do not fill before 60 days before that, and you put the dates on the prescriptions. You have to give the patient all 3 prescriptions on the same day, dated the same day it was written. That's the only way to legally give more than a 1 month supply of a Schedule II drug. We do that for our attention deficit disorder drugs, for the Ritalins, the Adderalls, those kind of things, so you don't have to see them every month. You can give them 3 prescriptions. That's still okay with these guys. That's all Schedule IIs you can do that with, but no refills. Okay? So that's the new law. The other thing that happened back in August, the DEA also scheduled Tramadol Ultram. And again, some states had already scheduled it, but it wasn't scheduled nationally. The feds had not scheduled it. It's now Schedule IV. So we have new scheduling as of August for Ultram, Tramadol, and any combination product that has it in it is now Schedule IV. That's new as well this year. We also have a controversial drug that was approved last year, Zohydro. And this is sustained-release oral hydrocodone without acetaminophen. This was the first and only single-component hydrocodone, and it's sustained-release 12-hour formulation. And it has no current abuse deterrent in it. And that's been the rub for a lot of people. So Zohydro has either 10, 15, 20, 30, 40, or 50 milligrams of hydrocodone per dosage unit, good up to 12 hours. And if you or I had not been on hydrocodone and we were to take a 30, 40, or 50 milligram tablet twice a day, we wouldn't be here today. That's the problem with it. It's only for people who need long-term hydrocodone that have significant tolerance specifically to hydrocodone where you use those kind of doses. And it's the first FDA-approved opioid that meets the current REMS requirements for all long-acting or sustained-release opioid products by the FDA. It meets the FDA REMS program. So let me look at a couple of things on it. Oh, also, earlier last month, the company who makes it submitted a revised formula to the FDA for approval with some tamper resistance in it. So there is a new formulation coming. It's been accepted by the FDA, not yet approved. So there will be an abuse deterrent formulation of this drug. That's been the most controversial issue. It's approved for chronic opioid needing patients, not PRN, and not for acute use. It should never be used for acute pain, should never be used on a PRN basis. It's scheduled for chronic pain patients, your cancer patient who has a high tolerance to hydrocodone, specifically hydrocodone. And you don't start anybody on a high dose. The dose is started at the 10 milligram lowest dose, Q12 hours. You don't increase the dose any more often than every 3 to 10 to 7 days. About once a week, you can go from 10 up to 20, up to 30, up to 40, or up to 50, and no more than 10 milligram increments twice a day. That's what the label says. Okay? And you can't depend on conversion tables converting from one opioid to another to show cross tolerance. It gets us into trouble. Opioids for pain are the leading cause of drug overdose in this country today, the ones we prescribe for our patients. Not talking about non-medically prescribed, illegally obtained drugs. Talking about patients who have unintentional overdose and death due to the drugs we prescribe. And it's because we are not familiar enough with the pharmacokinetics of the drugs. We tend to increase the doses too rapidly, in too high an increment. All those reasons are driving it. And we've got to pay attention to these drugs. So this is the new labeling. See how it comes, and the recommendations for dosing no more than every 3 to 7 days to increase the dose. We also have another drug that this whole problem has led to, Invizio. Invizio is an auto-injector of naloxone Narcan, the opioid receptor antagonist. And a lot of us have been using this drug for years, and we've been giving our patients naloxone kits. We'll actually give them the vial with the Narcan and naloxone in it with a syringe and instructions what dose to use and how to use it. And that costs about $20 to $25 to give them 2 vials with 2 syringes and the instructions. This auto-injector comes with 2 auto-injectors with actual drug. This is what it looks like, the yellow and purple, the actual drug, and a black and white trainer. So it comes with 3 different, in a box of 3. One is a trainer for repeated use, and the other is single dose uses. The problem is this costs $575. And you could make your own for $20 or $25. Same drug, but it's not going to have the auto-injector, and it's not going to talk to you. And this auto-injector talks to you. You pull it out of the case, and it says, if you're ready to use it, pull off the red tab at the bottom. So you pull the red tab off the bottom, then it says, take and push it against the outer thigh, and push down until you hear it click. It will auto-inject. You hold it there for 5 seconds, then you pull it out, and the needle is gone. The needle goes in and out, so it's protected, and it's once and done. And they talk to you. They tell you how to do it. It counts down the 5 seconds on how long to keep it there. And it's FDA approved, including children less than 1 year of age. And if you use it in kids, young kids, it tells you have to pinch the leg to keep it up to get enough skin for it to inject. It's the same injector for kids and adults. There's no like EpiPen Jr. There is no difference. It's all the same. It's 1 dose for everybody. And what does it do? It knocks the opioid off the receptor. And the major thing we're trying to prevent from happening is respiratory depression. That's what it's going to knock off very, very quickly. But when it does it, if you've got a chronic pain patient, their pain relief is also gone. It puts them into opioid withdrawal right away. So if you got a drug-seeking person, no way they're going to want to use this drug. Okay, so that's how it works. And the reason you have two is the opioids have longer half-lives. These are relatively short. You may need to give a second dose, even though you call EMS. You give the first dose and you call EMS right away. Okay? And if they're on a synthetic opioid receptor agonist antagonist like buprenorphine, that takes a higher dose of naloxone to bump it off the receptor than regular opioids do. So if somebody's on one of those drugs, you may need to give 2 doses before you see the full effect. And again, the duration is shorter than the opioid. So you have to be aware and activate EMS when you give the drug. So IM or sub-Q, it doesn't matter. Additional second dose can be given 2 to 3 minutes after the first. If they're still having difficulty with respirations, they're still snoring, they're not arousable, those kind of things, you want to continue to give another dose. Onset is fast. Within 15 minutes you get the full effect. Duration is relatively short. You see the half-life is about 1.5 hours in most adults, and in neonates the half-life's a little longer, up to 3 hours. Will experience opioid withdrawal. The good news is opioid withdrawal is not life-threatening. Patients hate it, but it's not life-threatening. It's not like barbiturate withdrawal, CNS depressant withdrawal. It's not as bad. So that's the Invisio. Questions on it? And some states, they didn't want it to be made available, but it's an FDA-approved drug. It's not a scheduled drug. It's just requires a prescription, and we've been doing it anyway. And most people in states that already have programs are still going to probably use the homemade ones because they're $20 or $25. And we're pending FDA approval on a nasal spray, which will do the same thing. We've been using Narcan injectable intranasally in some of the kits with a little adapter on the syringe for nasal installation. So either way it works. They both work equally well. So that's the data there. A couple of new things with digoxin. I hope by the time you leave today, you'll take the pledge that we don't want to start anybody new on digoxin. After 300 years, it's time to say, goodbye, Dig. Thank you, but goodbye. William Withering, his time has come and gone. This is some data from Kaiser Permanente, published a year ago, and it's about 2,900 patients with newly diagnosed systolic dysfunction or reduced ejection fraction heart failure. 18% received Dig, and this is from the Kaiser Permanente group out in California. And they followed them over 2.5 years. If you look at the death rates, if they got Dig, the death rate was 14.2% versus 11.3 person years, and hospitalization was higher. So 72% relative greater risk of death if you got Dig versus not getting Dig. Now, even June of last year, when the current guidelines for heart failure came out by the American College of Cardiology, American Heart Association, Dig is still there. It's down on the list, but it's still there to reduce hospitalizations and to improve quality of life. Well, it turns out that's based on a study that most of us remember called the DIG trial, DIG, Digitalis Intervention Group trial. And when the DIG trial was done, the only evidence-based drug for heart failure used in the trial was an ACE inhibitor. There were no beta blockers included. Beta blockers were not approved and recommended for heart failure when that trial was done. Now, beta blockers are part of the gold standard therapy for people with heart failure. And you put a beta blocker, ACE or ARB in the mix, which are evidence-based, and throw Dig on it, that's what they did here. So without beta blockers, Dig in the original Dig trial did not increase mortality unless you had higher levels greater than 0.8 or 0.9, and why we were at Dig light, and it reduced hospitalizations. This data suggests even at low levels it increases mortality and does not reduce hospitalizations. So Dig, and the editorial that's got to be by Dr. Opie said, Digitalis yesterday and today, but not forever. And he says the current guidelines need to be revised already. to take DIG out of the equation. So this is one of the studies with DIG that we've had in the last year and a half. This is the other one just published in the American Journal of Cardiology in the last 3 months. This is Treat AF. This is DIG for atrial fibrillation for rate control. We still have a lot of folks with AFib that are on DIG for rate control. And this looks at outcomes comparing DIG to the other rate-limiting drugs, beta blockers, rate-limiting channel blockers, verapamil and DILT. Again, 23.4% at the VA. This is 122 outpatients who had newly diagnosed non-valvular AFib. Cumulative mortality, 95 versus 67 per 1,000 patient years. Again, suggesting increased death rate if they had DIG for rate control for AFib versus any other drug, beta blockers, rate-limiting channel blockers. So is it time to say goodbye to DIG? Those are the two major indications still left. And both of these trials suggest the outcomes are not what we want. And DIG is not a drug that keeps you in normal sinus rhythm. It's not an antiarrhythmic. All it's used for is for rate control. And it's not as good or predictable as beta blockers or rate-limiting channel blockers, and this suggests increased mortality versus beta blockers or rate-limiting channel blockers. So again, it's time to say goodbye to our friend Digitalis. We probably should not be using it at all today. And there are a huge lot of patients out there still on it. Probably not a good thing. And if you were using it, in the old days, we didn't care what dose we used. We got the heart rate to where we wanted. And we didn't look at the DIG level. And we now know that's wrong too. So again, if we were going to use it, it's lower doses, DIG light, and lower levels. But even that, which is what was used in both of these trials, still increased mortality and did not reduce hospitalizations. So time to say no more DIG. This is also interesting, and I wish I had a good head-to-head study. I don't. This is a meta-analysis looking at all the data with ACE inhibitors versus ARBs in patients with diabetes. Whether they're hypertensive, normotensive, kidney disease, or no, it doesn't matter. And if we look at the data, treat with ARBs did not reduce all-cause mortality, relative risk 0.94, cardiovascular death rate, major cardiac events, or heart failure was the only thing reduced with ARBs. If you look at the data, and I might have hidden the wrong slide. Yeah, I hit a slide I shouldn't have, but that's okay. All those outcomes are improved in ACE inhibitor-treated patients. Every one of those is significantly reduced with an ACE inhibitor, and the only one significantly reduced with an ARB is heart failure. And these are patients with diabetes treated with an ACE or an ARB. ACE is still the place. That's where the evidence is. And the other thing that the ADA is recommending for everybody with diabetes, at least one of your blood pressure drugs, ACE inhibitor ideally or ARB, should be given at bedtime, not in the morning, to treat nocturnal hypertension, especially the, quote, non-dippers, people who don't drop their blood pressure when you go to bed at night. And you can convert non-dippers to dippers with at least one drug at bedtime. So the ADA in 2012 said at least one antihypertensive med should be given at bedtime in everybody with diabetes, level evidence A. I don't agree with the level of evidence. It's a single study from a single center in Spain called the MAPEC trial. It's based on 448 patients with diabetes. But if they got at least one blood pressure drug at bedtime versus all in the morning, major cardiac events were reduced, relative risk reduction 75%. That's why the ADA gave it level A evidence. It needs to be replicated, and I believe University of Iowa is doing an NIH-funded trial to look at it, but right now, that's where the evidence is. And the HOPE trial with ramipril in people with diabetes or prediabetes was dosed at bedtime. And that's the best ACE trial in people with diabetes, the MicroHope, showing the greatest reduction in events, and the only one that mandated bedtime dosing of an ACE inhibitor. So again, I know you talked about hypertension earlier this week, but I think this is an important caveat. What drug to use and why? These are the guidelines by the American Academy of Neurology for non-valvular AFib to reduce the risk of stroke. And a couple of things that you'll note. Patients with non-valvular AFib with no risk factors have an absolute risk of major bleeding of 3% per year and stroke risk 1.3%. So if you're low risk, there is no recommendation in the guidelines to treat you with an anticoagulant or aspirin because the outcomes are not significantly different and the risk may be worse than the benefit. Now, if you do have an elevated CHADS-2 VASC risk score for stroke, then anticoagulation is preferred, and they suggest warfarin, dabigatran, rivaroxaban, or apixaban, and soon to be, the FDA Advisory Committee voted this week to approve edoxaban, another 10A inhibitor for the same indication. So we will have 3 10A inhibitors, 1 direct thrombin inhibitor, and warfarin. We'll have 5 options for anticoagulation for these patients, all that will be FDA approved. Now, this is an interesting table. This is from the American Academy of Neurology, and if you look at the top one, stroke or systemic embolization, clopidogrel is not as good. Warfarin is better up here, and I don't think my pointer, I can't see it, so the dabigatran 150 is significantly better. Every one of these trials was designed as a non-inferiority trial versus warfarin. Adjustable dose warfarin INR target 2 to 3, and they met non-inferiority. Then they were tested for superiority. And dabigatran 150 met superiority. 75 was not used in the trial, so there is no data on the FDA-approved dose of 75, and the 110 was used in the trial, is not FDA-approved. Ah, good. Yes, we can see this one. So that's where clopidogrel and aspirin is not as good. Dabigatran is significantly better. Anything that doesn't touch this line of unity is significantly better. Rivaroxaban trends in the right direction. It's non-inferior, but they can't say it's superior. Okay? Their trial, Rocket AF, did not show superiority. And then this one is the apixaban data, and it also shows superiority. It doesn't touch the line here. So apixaban was non-inferior and tested superiority was superior. So we've got 2 that are superior to warfarin, 1 that's equal to warfarin. Ischemic stroke, all trending in the right direction, except again, Plavix and aspirin not as good as warfarin. If I get major bleeding, everything's the same as warfarin except this guy, and that's apixaban. So apixaban is the only one that has data suggesting a lower bleeding risk than warfarin. My number needed to treat is still over 100 to have 1 less bleed. And then when I go down to intracranial bleeding, they're all in the right direction. Clopidogrel aspirin is not significantly better. The other 3 are all significantly better than warfarin as far as intracranial bleed. And GI bleeding, dabigatran is significantly worse. So is rivaroxaban, and apixaban is non-inferior and trending towards better. So that's the table from the American Academy of Neurology when it comes to their recommendations. I'll show you what they recommend. So these are the drugs, and here's your numbers needed to treat. So if I look at dabigatran in the RELY trial, my number needed to treat to have 1 less stroke or embolization is 173, no difference in major bleed, but a significantly increased risk for GI bleed. Rivaroxaban does not meet the requirement for superiority, so you can't calculate a number needed to treat, and major bleeding is not significantly different, so there's no number needed to harm or to treat there either. When you come down to apixaban, in the Aristotle trial, my number needed to treat to have 1 less stroke or embolization is 303. It's significant, but you've got to treat 300 patients, and major bleed, my number needed to treat is 105 to have 1 less major bleed with apixaban versus warfarin. So that's the data from the major trials. So what do they recommend? If you've got a patient at risk for GI bleed, their guidelines say might offer apixaban who require anticoagulation because it's the only one with less major GI bleeds versus warfarin. So they say that. But if you can't do that for INR monitoring, then any of them is okay. And unsuitable for warfarin, they prefer apixaban, again, based on superiority in bleeding, superiority in efficacy, and is the only one that has a mortality benefit that's significant as well in the trial. But again, a high number needed to treat. But again, if you can't get apixaban due to coverage or whatever, any of them are appropriate, dabigatran or rivaroxaban, according to their guidelines. So that's the new guidelines from the American Academy of Neurology. Same thing, we have new guidelines from the American Heart Association, American College of Cardiology, for AFib. They want us to switch to the CHADS-2 VAS score instead of the old CHADS-2 rating system. So women get an extra point. 65 is a point instead of waiting to 75. You have a history of vascular disease, you get 2 points. So all those things are brought into the equation. And they recommend warfarin, dabigatran, rivaroxaban, or apixaban are all included in their recommendations. They don't prefer one over another. They do say for the first time there's little benefit with aspirin. So aspirin is no longer routinely recommended for your low-risk patient for stroke prevention. The Japan aspirin study, there's no difference versus placebo. A meta-analysis out of the Netherlands, no difference with low-dose aspirin versus placebo at reducing the risk of stroke. So aspirin has been moved to the back of the bus. And they also, for the first time, give you ablation as an option, but they say if you're not a candidate for anticoagulation, that does not mean you're a candidate for ablation. Because if you ablate, you may still need to be anticoagulated. And ablation doesn't always work. So you can't always say, if you ablate, the reason I'm ablating is because they're not a candidate for warfarin. So they say that in their guidelines. Questions on the AFib stuff? Asthma COPD. This has been the fastest changing new drug environment in the last year and a half of any class of drugs. And there are 2 major players that are coming forward with new drugs that are all once a day. 7 of the 8 are going to be for COPD, only 1 is for asthma. So most of this is COPD. So the first one we have is the Breo Ellipta by GSK Theravance. And this is a once-a-day combination of ICS-LABA. So it's the ICS, the inhaled corticosteroid, that's fluticasone furoate. Not what's in Advair, it's what's in Veramist, the nasal spray they came out with that's once a day. So it's a 24-hour duration formulation of fluticasone. It's a different salt. Fluticasone furoate is once a day. Along with Vilanterol, and Vilanterol is a 24-hour duration long-acting beta agonist, similar to salmeterol or formoterol, which are a 12-hour duration. So this was the first once-a-day ICS-LABA, and the only one right now that is once-a-day ICS-LABA. But it's not approved for asthma. It's only approved for COPD. It's like Advair, but it's once a day. Advair is twice a day, and Advair is approved for both COPD and asthma. And it has the same box warning as all the other LABAs do. Asthma-related death is still in the box warning, based on the SMART trial with salmeterol. So this one's once a day for maintenance of COPD. This is what the inhaler looks like when it's closed. It's got a blue cap, and it's got a counter on the front that's real easy to see, 30. Now, with Advair, you have to take the dust cap and move it off, and then there's a lever you have to activate the drug. With this one, all you do is open it, it clicks, you've activated the drug. So every time you open the cap, you activate the drug. And if you close the cap, that dose is gone. You just lost $10 because it's $10 a dose. So if somebody sits there, opens and closes it 3 times, they've just lost $30 and you can't get it back. Because there are 2 blisters in every time you open it that are exposed. And the dry powder is there. And if you open it and you turn it down, the powder falls out. So you got to pay attention how you hold it. So it needs to be held level once you activate the dose. And it also has, and I'll show you in a minute if I can, this is what it looks like when you open it. And the only place that air comes in is right here. So if you take and hold it and put your finger over that vent, you're not going to inhale the drug. Okay? You got to show them how to hold this thing. You got to show them how to open it, how to hold it and what to do with it. Because otherwise they're not going to get the benefit of the drug. Not true for Advair. Advair has holes all the way around underneath it. So it doesn't matter how you hold it. Advair doesn't activate the drug till you push the lever down. So there's some downsides, I believe, with this Ellipta inhaler. And they're all called Ellipta. So every time you open this counts down one because the drug that used to be there is now gone. And even though it's 30 doses, if you're a pharmacy and you're buying it, it's going to have a package size of 60 because there are 60 blisters to give you 30 doses. So each dose that you activate is opening 2 blisters. That's why the package size says 60, but it's only 30 actual doses in it. And when you get down to, counts down to 0, you don't start over again. Even if you didn't use it, it doesn't matter, it's gone. So it's once and done. So it's really important that you show patients how to use this inhaler. Let me back up. So what you have is a cost. Wholesale is about $260. Patients are going to pay out of pocket $300 for it. So it's about $10 a dose if you had to buy it out of pocket. So it's similar to Advair in cost, Symbicort, as well as Dulera, which are all the other twice-a-day ICS LABAs. The others have Formoterol, Salmeterol, which are twice a day, with fluticasone or memethazone. This one is fluticasone and Vilanterol. And the combination is better. FEV1 at peak and at trough for 24 hours. You can see there's still some better effect early on, and it does tend to level off towards the end of the dosing interval, but it's still significantly better, and the combination is better than either agent alone in their head-to-head studies. So box warning for asthma-related death, not indicated for asthma. Now, the second one that came along is Anoro, and this one I like even better. This is a combination of umeclidinium, which is a long-acting antimuscarinic. This is a LAMA, a once-a-day like tiotropium Spiriva. And it's a dry powder inhaler mixed with Vilanterol, the LABA, the same LABA that's in Brio, is in Anoro. But it doesn't have an inhaled steroid. It's a LABA-LAMA combination. The first combination of a long-acting beta agonist with a long-acting antimuscarinic. Okay? Only approved, again, for COPD, not indicated for asthma, and it has a red cap. There are 4 of these guys now FDA approved with this delivery system. They're all the Ellipta inhalers, so they all say Ellipta after their name, but they all have a different color and they have a different trade name. So the first one was Brio, this one's Anoro. Again, once a day, exact same delivery system, so you open the cap, you activate the drug. It's got the same vents, exact same inhaler. And in fact, if you've seen the demo by the company, it's got a gray cap, and it's just called the Ellipta demo. So it's the same demo for all 4 of their new inhalers. So there's one demo for all of them. They look a little bit, the inhaler's the same, the color's what's different. Now, this one, it's got the same box warning because it has the Vilanterol in it, so it does have the long-acting beta agonist, so the asthma-related death is still there. The half-life allows once-a-day dosing. And the FEV combinations versus monotherapy are significantly better again, both at peak and trough. So the combo is better than either agent alone at improving FEV1 in patients with COPD. This is a new trial they just released a little over a week ago, 905 patients COPD, comparing umeclidinium plus Vilanterol head-to-head to Spiriva. It's not a fair comparison because there's no LABA in the Spiriva group. And it does show superiority at pulmonary function tests again. The combination is better than just using the anticholinergic. Now what's interesting, there was a trial in New England Journal a couple of years ago called the POET trial, POET COPD trial. They compared Spiriva head-to-head to Salmeterol. Okay? And Spiriva beat Salmeterol in improving lung function and reducing times or increasing time between exacerbations. So if you look at the GOLD guidelines from 2014, a LAMA is probably a little better than a LABA for people with COPD. And we now have data the combination LABA/LAMA is better yet. And this is already in the 2014 GOLD guidelines, LABA/LAMA. So if I've got somebody with severe COPD, my primary drug that I'm probably going to offer them for prophylaxis would be a drug like this, the LABA/LAMA, without the steroid. Because again, the steroid is the least effective for COPD of these three classes of drugs. So the most effective are the LAMAs, then the LABAs, then ICS. So LABA/LAMA is where most of us would probably go for our severe COPD. Convenient once a day, but again, it's got a price tag about $300 for a month's supply, with the same concerns about how to use the inhaler. So that's the data just presented and published in Respiratory Medicine. Drug interactions, vilanterol is a 3A4 substrate, and it is a long-acting beta agonist, so it's going to increase heart rate. And there are some concerns that these drugs, so do the LAMAs, increase heart rate, the anticholinergics. So together they're even more. And depending on some of the studies, heart rate has gone up in some patients as much as 9 to 20 beats a minute. So there's also a concern about cardiovascular effects of these drugs as well. And we don't have a lot of outcome data one way or the other. So there's been some concerns, but we don't have good alternatives, because most of these patients continue to smoke and their lung function is going to continue to decline until or when they quit smoking. The only thing that makes a difference long term is stopping smoking. None of these drugs prevent progression. They're symptomatic therapies only. They do not prevent worsening the disease. There is no disease-modifying drug other than stopping smoking for these patients. So that's an important thing to remember with our patients. And you have to watch out for all the anticholinergics, the LAMAs, when it comes to men with BPH. It's going to worsen urinary retention. And it will increase heart rate as well. Both components, you can see the 9 to 20 beats a minute increase in heart rate, and the cost is, again, about the same, right at $300 if the patient had to pay for it out of pocket. So that's already out. The next one is coming out in the next, I believe, this month. Incruse, which is umeclidinium by itself. So this is a once-a-day LAMA without the steroid or without the long-acting beta agonist. So this is the Spiriva-like drug by itself. So this is the equivalent to Spiriva, and it's a once-a-day dry powder inhaler with this delivery system. And you can see the difference versus placebo on FEV1 at day 169 was 280/115 mils with peak to trough. And this is what it looks like. It's got a green cap. So each one's got a different color. It's the only way you're going to look at them and see which inhaler you're talking about, other than the name that's on it. Because it's identical inhaler, same counter, everything's the same. They're used exactly the same way. Haven't seen a price on this, but I'll bet it's going to be in the same ballpark. So this is the FDA approval of the fourth one that will be launched, I believe, in January. And this is the only one for asthma. This is our annuity. And this is fluticasone Faraweight by itself, dry powder for asthma. So this is the only once-a-day long-acting corticosteroid inhaler. And this one has an orange cap. I'll show you the picture of it in a minute. Not indicated for acute bronchospasm. And the 100 microgram Faraweight salt was similar to 250 of the Advair twice a day, or the fluticasone propionate that's in Advair. So the 100 microgram dose, standard dose for this, is the same as the 250 fluticasone twice a day. So they've done the study to compare them head to head.
How much is that?
We don't know yet, but it's probably going to be in the same ballpark. I'm going to bet $10 a day. Don't know for sure. And it will be at a 100 and 200 supplies as a light gray with an orange cap, and that's what it looks like. So it's the same inhaler with an orange cap. And this is the only one for asthma. The other three are only for COPD. This one's only for asthma. So that's the Theravance GSK new line of inhalers. The other line of inhalers, that there are now 3 and soon to be a 4th one, are the Respimats. And the first one of these was last summer, the Combivent Respimat. The old Combivent MDI is no longer available as of last summer. They moved to the Respimat. And the Respimat is a liquid inhaler, and it's a slow mist inhaler. It continues to put mist out for 3 seconds when you activate it. It's not a blast. It's a slow, steady release for up to 3 seconds. You can actually see the cloud for 3 seconds after you activate it. Okay? So it's the Respimat, and there will soon be 4 of these. And they're all going to have different color caps as well. So the first one was Olodaterol Straverity. And this is a LABA, once a day, long-acting beta agonist for COPD. Okay, so that's only approved for COPD, and it is a long-acting beta agonist by itself, like Vilanterol. Not indicated for exacerbations, not indicated for asthma. It's got the box warning, and available in a 60-spray Respimat, which again is 30 doses. It's once a day, but each dose is 2 inhalations. So you need to inhale the first dose, reactivate it, and inhale a second dose once a day. So it's 1 dose with 2 inhalations once a day. So it's got 60 sprays in the canister, but it's a 30-day supply. And this is what it looks like. It's got a yellow cap. And the yellow cap, the Respimat for Combivent has got an orange cap. This one's yellow. And this is just the LABA. And it doesn't come put together. So the canister that you see here on the side, and this is again going to be the same for all of them, this is a little canister that has a liquid in it. You take the cartridge, you take this clear cap off the bottom of the Respimat, and you slide the cartridge in. It only goes in one way. You push it in until it clicks. Then you take the clear plastic cover and clip it on. It actually clicks on. Okay? And in order to activate the dose, you turn that clear plastic cover 180 degrees and it will click. And what you'll see happen is this canister will actually come down. It'll slide down when it's activated. And this is the dosing button. And if it's not activated, that button doesn't do anything. It doesn't push. When you activate it, you're ready to take the dose, the button pops out, and this canister drops down. That's how you can tell it's ready to go. And then you administer the drug, and when you do, you get that 3-second release, slow release of the drug for you to inhale, and the mouthpiece will accept a spacer. The universal spacers will fit on this, although you don't need it. Okay, but they will if you want to use it. This accepts a spacer. The other ones I showed you do not. This one does. And this button will depress, and then to activate the second part of that dose, you turn it 180 degrees, it clicks, and again you see the canister drop, and the button pops out. You're ready to take the second inhalation. And there are going to be 4 of these guys, all work exactly the same way. And they have a counter built in on the side. So you can actually see a counter on the side, see how many doses are left. But again, it's a once a day, but it's 2 inhalations per dose. So there are 60 doses, and you need to prime it the first time. And once you start, and when you start to see the mist come out the first time, you go ahead and do it 3 more times, then it's ready to go, and you don't need to prime it again unless you're not using it on a regular basis. Because otherwise you're spraying money into the air. Okay, because I don't know, but this one probably is going to be in the same ballpark cost-wise. So that's the Straverity. And you can see the FEV in changes in liters, so 150 to 200 mil increase at 12 hours, at 24 hours 110 to 150, and at trough 100 to 130 mil increase in FEV1, just with the LABA. There's no ICS, there's no anticholinergic in it. Just approved the end of last month was tiotropium Spiriva in a Respimat. It's still got the HandiHaler, but it also now has a Respimat approved by the FDA. So we'll have Spiriva in the Respimat, same type inhaler, and this one has a blue cap, I believe. Yep, so this is a light blue cap, exactly the same. No difference in the Respimat format. It's done the same way. It's once a day with 2 inhalations per dose. Instead of the contents of 1 capsule once a day, it's 2 inhalations once a day for this one. And pending FDA approval is a combination of tiotropium Olodaterol, another LABA-LAMA. combination. So like Anoro, you'll have another one with a different delivery system. And this is at the FDA awaiting approval right now. And it'll have a different color cap, I'm sure. That's the only way you're going to tell them apart. And you can see the Tavito is what their program is called, and don't know what the name's going to be for the drug. So questions on the new COPD drugs. So lots of new things happening in that arena. Hepatitis C. This is also a very, very fast-moving target. And I put this out because this is where you're going to find your guidelines. The American Association Study of Liver Disease and the Infectious Disease of America have collaborated on guidelines for hepatitis C. They were first put online in January of this year. And they've been updated 2 or 3 times, and they need to be updated unless they were updated in the last 2 days to include the new drug I'm going to share with you next. So this is the place to go to look at the guidelines for hepatitis C. So last month, the FDA approved a breakthrough drug, Harvoni, which is Sofosbuvir, which is Gilead's drug that was used in combination with interferon and ribavirin. It was in the guidelines as preferred for every serotype of hepatitis C. Well, we now have a once-a-day oral combination drug, and this is also a breakthrough drug, 1 pill once a day for 12 weeks, looking at 94 to 98% eradication rate of hepatitis C. 1 pill once a day for 12 weeks. Without interferon, without ribavirin. Monotherapy with 1 single pill combination. So it's indicated only for right now for genotype 1, although there's data for other genotypes. We'll have to wait and see what the guidelines say. First regimen does not require interferon or ribavirin as part of the regimen. There are trials, 3 trials in over 1,500 patients who had not previously treated, and they also have those with cirrhosis. So if we look at the data, treatment naive, 94%, 8 weeks, 96%, 12 weeks, maintains sustained viral response. No detectable virus at the end of 8 to 12 weeks. Okay? Monotherapy, 1 pill once a day. 99% without cirrhosis or with cirrhosis at 12 weeks in the IN2 trial, and those who have had experience, they've failed other therapy, 94% at 12 weeks, 99% at 24 weeks. So the only time it's more than 12 weeks are those who have failed other therapies. You can go out to 24 weeks if you can afford it. Because here's your cost. $1,125 per tablet. $94,500 for 12 weeks. $190,000 for 24 weeks worth of therapy. 1 pill once a day. Wonderful eradication rates. Can cure the disease. But can we afford it? That's the question. Solvity, which is just the Sofosbuvir combination, was approved last January, will sell in excess of $8 to $10 billion this year in sales. The most successful drug ever launched in the history of the pharmaceutical industry, first year sales between $8 and $10 billion. It costs $1,000 a pill, and this is $1,125 a pill. Same company, Gilead Pharmaceuticals. Now the thing that is interesting is that's what we pay for it. There are 60 countries in the world that Gilead has licensed 4 generic manufacturers to make these drugs for. And they're sold for less than $1,000 a 12-week course in those 60 countries. You can go to Egypt and buy a 12-week course for $600. For us, it's $84,000 for Solvity, and this one's $94,500. We're the only country in the world that doesn't have price controls. No other country in the world is paying this price for this drug. We're the only country in the world. The state of California last year said if we treated all the hepatitis C patients in the state of California under Medi-Cal It would cost us $18 billion for Solvity, their drug, as part of the regimen. Can't afford it. So what have we seen happen? Restrictions. So the number one restriction that we're seeing, and we've got it in South Carolina, almost everybody's got it. The only way to get access to the drug, you got to have end-stage liver disease to qualify for the drug. You got to prove you got cirrhosis or fibrosis to get access to the drug, because it works just as well when you get that far. And it prevents liver transplant if we go that far. But we can't treat people just because you're hepatitis C positive, because we don't know if you're going to get to end stage. We don't know if you're going to develop cancer. We don't know if you're going to need a liver transplant, because we can't afford to treat everybody. That's the conundrum we're in right now. I believe this is the goose that's going to lay the egg that causes Congress to go back and look at Medicare Part D to allow negotiation or price controls. I think it's going to come. The industry is moving so far, and it's not based on what the drug development costs are. It's based on what they think the market will bear. And right now, this is a disease which has bad outcomes. This is a game changer. This cures these people with this disease. But at what price? That's the issue. I wish there was a magic answer. I wish I could tell you this is what's going to happen. I don't know what's going to happen. Yes, sir.
What about Canada?
Canada, again, they have price controls, but they're still willing to pay a lot more than we are. Than those third world countries. Just like the UK. The UK NICE people will set the price with the company. They negotiate a price on the front end they're willing to pay. Yes. It's cheaper everywhere in the world except for us. And when Medicare Part D legislation was written by the pharma lobby. It prohibits the Director of Health and Human Services from negotiating discounts with pharmaceutical companies. There is no discount allowed. It's written into the law that way. And again, our wonderful people in Washington pass laws without understanding what's in them. Just like the Accountable Care Act. Nancy Pelosi said, we don't need to read it. Pass it, then we'll read it. And there's some stuff in there that we don't like either, right? They didn't realize it was in there. That's part of the problem. We have got to do a better job. And hopefully next Tuesday you get a chance to express yourself. Please express yourself. You can't tell where I am. There are some drug interactions that are listed here. I won't dwell on them because I want to get on with some other things, but they are listed here for you. Yep. And here's the side effect profile. Look at the side effects. These are well tolerated drugs. This combination has minimal side effects except in your wallet. That's the only adverse effect with this drug, the cost. The efficacy is clearly there, 95 to 99%, and fatigue is the most common side effect at 13 to 18%. And this is, again, you don't need interferon, which is the one that nobody likes to be on. This does away with interferon and ribavirin. It's one pill once a day. So this is like single pill therapy for HIV, only this is for hepatitis C. Questions on that one? Yes?
Does the VA cover?
The VA, yes, and again, most of the people are making sure you're a candidate where it will make a difference in outcome. They're not treating you just because you are in that position. Yeah. So empagliflozin is the third SGLT2 inhibitor. This is for type 2 diabetes. And this one was approved in August, and this is a combination of Lilly and Boehringer Ingelheim. It would have been the first SGLT2 inhibitor approved by the FDA, but it's made in Germany in a Boehringer facility, and the FDA did not approve that facility originally. So there were some production problems and why it's not the first one on the market. Canagliflozin, Invokana, and dapagliflozin for Forxiga beat it to the market. So this is the third drug in the same category. They all work the same way. And these are not unique to people with diabetes. Do the same thing for you if you don't have diabetes. What it does, it lowers your renal threshold to eliminate glucose in your urine from whatever your normal is. And for most of us without diabetes, it's about 180 milligram per deciliter. You go above that, you spill glucose in the urine. If you have type 2 diabetes, it tends to be a little higher, closer to 200 or 220. But this drops it to 70 to 90 milligrams per deciliter in everybody. So if your blood sugar is normal at 100, you're still going to spill glucose in your urine even if you don't have diabetes if you take this drug. Okay? Because that's what it does. It's not unique to people with diabetes. It lowers your renal threshold for glucose elimination. So you spill glucose in the urine, so it reduces your caloric composition of your diet, so it helps you lose a little bit of weight. But when you have glucose in urine, what goes with it? Fluid. So you increase the risk of dehydration. So it produces what we usually see in previously undiagnosed diabetics, the polys. Polyuria. Okay? You may get some polydipsia because you're going to drop your blood volume. So you're at increased risk if you're older for dehydration. You're at increased risk for orthostasis if you're older, especially if you're on an ACE or an ARB, as almost everybody with diabetes should be. You're on a diuretic. All those things are going to be additive when you throw this drug on board. So there's a little bit of weight loss with it, which is a good thing, but it's doing it because you're peeing out glucose and pulling fluid with it. So you have to pay attention to that. And if you have impaired kidney function, it quits working, and it worsens your renal function. Got to pay attention to that with this one too. So the EMPA-REG outcome trial will be the first outcome trial with one of the SGLT2s. The other two also have outcome trials, but this one's the furthest along, even though it's the third one to market because it was delayed for FDA approval. Urinary glucose, spill approximately 64 grams a day with 10 milligrams and 78 with the 28. So 78, so let's say 80 grams of glucose a day, it's 4 calories per gram. So you're spilling 300 to 350 calories a day in your urine. And every 10 days, if it's 350, 3,500 calories you've lost, that's equivalent to 1 pound.
You're more likely to get a urinary tract.
Yeah, we're going to talk about that. He says more likely to get UTIs and vaginal and penile yeast infections. So the urine volume is increased, especially when you first start it, another 350 mils a day. It also looks at your A1C reduction and weight. So the weight reductions all the way over here on the right are really between 2 and 3 kilograms. So it's not magic at 26 to 52 weeks. The average weight loss is 2 to 3 kgs in all the trials. So you tend to stabilize the weight. If you look at the A1C reductions, they're 0.5 to 0.7 of 1%. So they're not magic, but they're in the right direction. So this is the empagliflozin data and all these combinations every way and the doses. There's not a significant difference in the dose reduction when you add it to anything. So it can be used by itself or in combination. And if you look at urinary tract infection you mentioned, you can see with the 10 milligram dose it's about 2% higher than with placebo. Female genital mycotic infections, 5 to 6%. And if they've had it before, it's 25 to 30%. So if you've had a history of recurrent yeast infections, it's much, much higher with this drug. All three of the drugs. These are similar for all three of the drugs in this category. If you look at increased urination, it's there. Dyslipidemia. By reducing concentration volume, your lipids go up, not down. Okay, so lipids go in the wrong direction. Blood pressure tends to go down, weight goes down, but lipids go in the wrong direction. We don't know what that means. GL mycotic infections, you can see 3% versus about 1/2, so about a 5 to 6-fold increase in balanitis due to Candida in males. 10 milligrams once a day in the morning with or without food. If they tolerate that and have normal kidney function, you can go to 25. Not indicated if your EGFR is less than 45 and discontinued when it drops to less than 45. Wholesale cost is $312. Retail is $350 for a 30-day supply. So it's more than $10 a day. You're looking at roughly $11 to $12 a day, and that's true for all three of the drugs in this category. And the A1C reductions are between 0.5% and 1%.
That's not going to get my patients to go.
Nope, not going to get most of us to go, is it? I'm one of them.
What is the advantage?
The advantage is they don't affect your insulin levels. They don't cause hypoglycemia because they don't affect insulin at all. All they do is cause you to pee glucose out. And a little bit of weight loss, so unlike insulin and some of the others that cause weight gain, and we don't know what it's going to do long term for cardiovascular events. That's in the process. And if you got impaired kidney function, can't use any of the three. You got to monitor renal function when it starts to decline and may have to stop the drugs, which is another concern. So at this point in time, I'm not a fan, but they're out there. And they're actually in the guidelines by the American Association of Clinical Endocrinologists as one of their preferred drugs to add on to metformin. And we do have a fixed combination with dapagliflozin and metformin just approved by the FDA this week. So a fixed combination of metformin with Farxiga, dapagliflozin, which was the second one of these drugs. So,
Wayne,
yes.
just a time check. We have about 25 minutes.
All right, 25 minutes. Let me show you a couple of things more about diabetes drugs. We have a new pen device for Bydureon. Bydureon was the extended release exenatide weekly. And you had to mix it, and patients had to take the tray, take it out, and reconstitute it and pull it up in the syringe by itself. There's now a new pen delivery system, but it's not user-friendly. This is what it looks like. You have to remove it from the refrigerator at least 15 minutes before you reconstitute it. So you can't think, I need to go get my dose, get it out and inject it. Got to take it out 15 minutes, reconstitute it. Once you do, you push it down part of the way. You've got to tap it and turn it in your hand 80 times to mix it up before you administer the drug. Okay? Not going there. I'm not going to recommend it. But tap the pen against the palm of your hand at least 80 times and rotate after each 10 taps to mix the powder in the diluent. That's in the label. And you got to take it out 15 minutes before you do that. So you got to anticipate the dose. So I'm not sure we'll go there. The third one of these guys, the first one was exenatide Byetta twice a day that has a nice pen you don't have to do anything with. Liraglutide Victoza, the once a day, is the market leader. It was the second one out. We'll come back to that. And it's once a day in a pen. It's just a light blue pen, but it's the same as a Novolog pen. You have to do is put the needle on it, and it's got the 3 doses. You dial 0.6, 1.2, 1.8. Abiglutide Tanzium by GSK was approved in April. It's also once a week. And the neat thing is, every one of these companies have compared themselves head-to-head in a non-inferiority trial with the market leader, Liraglutide Victoza. So we have Bydureon in the Duration 5 and Duration 6 trials, and it lost to Victoza. It was done by the manufacturer Bydureon, which is now AstraZeneca, that used to be Amylin, that used to be BMS, it's now AZ. It's been sold 3 times. Well, it turns out the Duration 5 and 6 trial, you didn't get the same A1C reduction. Victoza was better at lowering A1C, and Victoza was better with weight loss and paid for by the other companies. So Victoza didn't pay for any of these trials. It was paid for by the comparator. They lost. Well, they did the same thing at GSK, the Harmony 7 trial. And the GSK people are not going to mention Harmony 7 unless you ask them. Because again, it shows the same thing. It was a non-inferiority trial to Victoza. They lost. Less A1C and less weight loss than Victoza head-to-head with abiglutide. So their data. And if I look at the difference, abiglutide was minus 0.78 A1C, liraglutide was minus 0.99, weight loss minus 0.64 kgs abiglutide, 2.19 with liraglutide. Fasting glucoses, much greater again. All these are statistically significant in favor of liraglutide beating abiglutide. Fewer patients had nausea, and that's because it's a once-a-week formulation with a dose titration. So the longer-acting products have less nausea on the front end, but over time, that tends to go away. Has the box warning that's there for every one of the GLP-1s. There's 5 of these guys on the market now. 5 GLP-1 analogs. They all have the same box warning. Thyroid-related, thyroid seed cell tumors observed in rodent studies, and there are patients in every one of these drug trials that develop thyroid malignancy, more with the drug than in the comparator group. So they all have a requirement of ongoing surveillance for thyroid malignancy. And they require us to counsel patients. Symptoms of thyroid tumors: mass in the neck, dysphagia, which is probably the most likely one, dyspnea, persistent hoarseness. Any of those are a red flag to see your doctor and consider workup for thyroid malignancy. So that's to be counseled with every patient you dispense or prescribe this drug for. Pancreatitis has been reported with all these drugs as well. It's not a box warning, it's a precaution. And acute pancreatitis with all of them, and you need to counsel people on that. Severe nausea and vomiting, especially the abdominal pain, relates to the back, radiates to the back. Red flag, stop the drugs. 4-to-1 risk of pancreatitis versus any comparator in most of the trials with all the drugs in this category. If you've got a history of pancreatitis, you don't use these drugs. Dosage: 30 and 50 milligram single dose pens must be reconstituted 15 minutes for the 30 milligram dose, 30 minutes for the 50 prior to use. And again, the diluent is in the pen, but you have to reconstitute it. And this one, you roll, you don't shake and beat. Okay? You don't want to mix it up too much. You can roll it or gently, but it takes 15 minutes after the lower dose and 30 minutes to reconstitute the higher dose. They're not ready to give when you take it out of the refrigerator, get ready to administer it. The newest one approved in September is Trulicity, and this one is dulaglutide by our friends at Lilly. And this one's also a once a week. And they did, this is how it comes in a pre-filled syringe that you don't have to reconstitute. It's already reconstituted for you. All you do is put a needle on it and give it. And there's also a device that's an auto-injector. So it's got two different ways, and they're already reconstituted. So you don't have to worry about mixing them. Okay? You don't have to worry about the time limitations with this one. You can take it out and give it. Now, they did a study, the Award 6 trial. Same design. Non-inferiority versus liraglutide once a day. And this is the only one of the GLP-1 analogs that met non-inferiority for A1C. No difference in A1C between Victoza and Trulicity. It's the only one. It's not superior, but it is non-inferior. All the others thought they'd be non-inferior. They're all inferior. This is the only one that's not, including the 1.8 milligram dose of liraglutide, which I wouldn't use. And so the A1C reduction, minus 1.42 versus minus 1.36. No significant difference. If you look at the weight loss, Trulicity was minus 2.9 kgs, liraglutide minus 3.6. And it does show statistically greater weight loss with Victoza versus Trulicity, but they're both in the right direction. And it's got same box warning of thyroid and pancreatitis. Recommended dose is 0.75 weekly. You can go to 1.5 once a week for additional control. If you miss a dose, then you need to decide whether you wait to the next dose or go ahead and give it intermediately, and that's true for all the weekly formulations. So this is a once a week with an auto-injector or a pen that you don't have to worry about reconstitution. So there are only 3 you don't have to reconstitute. You don't have to reconstitute Byetta, that's twice a day, Victoza, that's once a day, or this one that's once a week. So you have a twice a day, a once a day, or a weekly, one option that you can not have to worry about patients having to manipulate and reconstitute the drug. No outcome data with any of these guys yet. So that's the comparison that's in there. And then the last drug I'll tell you about, Afrezza. This is going to be released. It was approved this summer by the FDA and Mankind Pharmaceuticals. This is the only fast onset, short duration, oral inhaled insulin. Exubera came and went. This is now FDA approved, and Mankind doesn't have a sales force. So when it was approved earlier this year, they didn't know how they were going to market the drug. So they were out looking for a partner. And they got Sanofi Aventis, the makers of Lantus and their Apidra injectable insulins, to buy on. They're going to promote this drug beginning in January. So Sanofi will have Afrezza by Mankind and be selling it. And it's going to come in little cartridges that are equivalent to 4 or 8 units of inhaled regular insulin. Human inhaled regular insulin. And this is the curve, what happens when you administer this drug versus 8 units of a rapid-acting insulin. So this would be as compared to, for instance, insulin Lispro, insulin Aspart. That's what this one is. This is Afrezia. Look what happens as soon as you take it. It's immediate onset. And how long does it work? It's gone within an hour, hour and a half. It's essentially out of the system. So very fast onset, but very short duration. This is if I gave you insulin Aspart Novolog or insulin Lispro Humalog, that's what you'd see. Delayed response and less of a peak, but a longer duration. So this is faster onset, shorter duration than any other insulin we've ever had. And it's human regular insulin for inhalation. And it's actually a dry powder. And here's the side effects. You can see cough is about 25% versus 19% with placebo, but that's still inhaling a placebo. So whatever they inhaled still caused some cough. Throat pain or irritation, you can see the side effects, but the main one is cough. And it does have a box warning that it can cause acute bronchospasm. If you have asthma, COPD, you don't use the drug. So you don't use it. And it does cause a reduction in peak flow, even in normal patients. So you need to have a pulmonary function test done before you start the drug, and you need to monitor that on an ongoing basis. That's in the label. There is a reduction in peak flow, and if you have a reduction of 20% and more while you're on it, you need to discontinue the drug. The average patient will lose about 40 mils at 3 months and 45 at 2 years. So usually about a 40 to 45 mil reduction in peak flow. When you stop the drug, it tends to be reversible. But if you have a 20% or greater, you got to stop the drug according to the label. And you need to do that baseline, and you need to repeat that after 6 months and then once a year thereafter. So for the first year, you do it twice, and then once a year thereafter, you do pulmonary function studies on anybody on the drug, even if they don't have any other abnormalities. This is what the inhaler looks like. If you remember, Exubero looked like a bong. Well, this one looks like a whistle. Okay, it's very small. And you take the cartridge that has 4 or 8 units of human regular insulin and put it inside and close it and take the mouthpiece off, and then you inhale the powder from that little whistle device. So it's oral inhaled. And it comes in blisters of 4 and 8 unit packages, and you take the drug out of the cap, and the blue one is 4 units, the green ones are 8, so they're color coded. You put it in and you close it, and then when you inhale it, once you activate it, this cup moves from the end to the middle, and that lets you know it's been used. I'll show you that. You got to keep it level because it's a powder and it will fall out just like some of the dry powder inhalers. So once you put it in and close it, hold it level, don't tilt it down, the mouthpiece down. And inhaler should be at room temperature for 10 minutes before you use it. So the cartridges can stay out once you open the blister for 3 days, and if you haven't opened the blister for 10 days out of the refrigerator. Otherwise, they're stored in the refrigerator. And you can see if it's used, it moves to the middle, and that means that cartridge has no longer got any drug in it. So it has to be the new one that's over here on the edge. And sealed for 10 days out of the refrigerator room temperature. Once you open it, take it out, have to use it within 3 days. And here's how you get the dose. So if you got somebody on 20 units of injectable regular or injectable Aspart or Lispro or Apidra, 20 units would be 1 of the 4s and 2 of the 8s. So they'd have to inhale 3 different blisters to get that dose. And here's how it comes. All different combinations of 4 and 8. Don't know what it's going to cost. They say it's going to be similarly priced to the dose of the pens. So we're looking at probably $300 to $500 for a month's supply. Because when you look at the pens, that's about what they cost, depending on the dose you're on. And they have to look at pulmonary malignancy, and they have to look at cardiovascular long term. We don't have any data. So those are condition of requirements for approval. Questions on Afrezza? I don't know how they're going to promote it because it's only with a meal insulin. They're still going to need to inject their basal insulin. And typically you go to basal before you go to meal insulin. So they're still going to, and they're going to want you, since Sanofi selling it, to use Lantus, because they're the people going to be selling it. So they're going to be positioning this as an alternative to Apidra, glulisine, their injectable fast onset short acting insulin. I'm assuming that's where they're going to have to position the drug. Newest hypnotic drug, Belsomra, by our friends at Merck, Survexant, and this is an orexin receptor antagonist. Orexin is a transmitter in the brain that causes us to stay awake. So we're suppressing one of the awake transmitters, orexin receptors at the 1 and 2 receptor, to suppress wakefulness. It's got a half-life of 12 hours. So it's going to stay around for 4 to 5 half-lives after each dose. So potentially significant risk for a hangover the next day. Okay? So it's a different mechanism we've never had before for helping us with sleep. And you have to take it within 30 minutes of going to bed and have to have at least 7 hours to sleep after you take it, according to the label. But remember, the half-life is 12 hours. So there's going to be a significant effect, potential hangover the next day, because it's going to suppress your ability to maintain wakefulness. That's how it works. So I'm not enamored by it. It was studied at 10 to 40 milligram and higher doses. It's approved at 10 to 20 milligram max dose by the FDA. 5 with moderate 3A4 inhibitors, and not recommended for strong 3A4 inhibitors, and food will delay the absorption. It doesn't work as fast. So if you want to take it 30 minutes before bed, you don't want to take it with a snack when you get ready to go to bed. Here's the data on sleep onset. Difference from placebo. Study 1, at 1 month, 10 minutes faster. At 3 months, 8 minutes faster. In study 2, 8 minutes faster at 1 month, and no difference at 3 months. That's what their label says. And then total sleep time, or not total, but wake after sleep onset, 26 and 17 and 24 and 31. So it's going to increase sleep time about 15 to 30 minutes, or reduce wake after sleep onset an average of 15 to 30 minutes. That's the data. And it does not affect sleep architecture. Sleep stages are not adversely affected. Does not depress delta wave sleep, stage 3 and 4, where you get your memory, creativity, and sexuality from. And it does not suppress REM sleep. Okay, so you don't have REM rebound based on limited data we have with it. 30 to 40 milligram dose in trials were not better than the 10 to 20. So the FDA did not approve the 30 and 40 milligram dose that was studied in all their trials. Only approved 10 to 20. Daytime somnolence is a risk factor. It's listed, as are sleep-related behaviors. Sleepwalking, sleep driving, sleep eating, the same thing we have on hypnotics. That's also in their label. They've seen some of that in their trials. So nighttime sleep behaviors, depression and suicidal ideation are listed in the label. Respiratory function, no data there. And sleep paralysis risk increases with the dose. So that's the newest hypnotic out there, Belsomra by our friends at Merck. Contrave was also just approved in the last 2 weeks. This is a combination for weight loss. This is a third new weight loss drug, and the fourth one is pending FDA approval, hopefully in the next couple of weeks. And that's liraglutide for weight loss at a 3 milligram dose. It's been recommended for approval by a vote of 13 to 1. Well, this was approved, and same indications as Belviq and Qsymia. If they don't lose at least 5% of their weight within the first 12 weeks, you're supposed to stop the drug. That's true for all these new weight loss drugs, and that's not going to be a lot of people. Most people are not going to lose that much weight if you look at their data, and I'll show you that in just a minute. The box warning is still there. Have to watch blood pressure, seizures, because it's got bupropion, Wellbutrin in it, and it has naltrexone in it. So it's naltrexone, bupropion, extended release is what's in Contrave. And if we look at side effects, lots of nausea, constipation, headache, vomiting, dizziness, insomnia, dry mouth, all those things are there in patients who take it. And here's their weight loss. And let me just, this is not very impressive to me. And there are 3 trials, the core trials. And if we look down here, difference from placebo, 4.1 kgs in this trial, 3.2 kgs in this trial, and 2 kgs in the diabetes trial. So 2 to 4 kilogram weight loss better than placebo at the end of 26 to 52 weeks. So you're looking at maybe 5 to 10 pounds. That's what the weight loss is. You stop the drug, guess what happens? It goes right back up again. And over time, it doesn't continue to stay down. It actually tends, most of the data suggests it trends upward, just not as fast as if you stop the drug. So again, these are not magic for weight loss. There is no magic pill. If there was, I'd take it. Okay? No magic pill. That's right. Or I had gastric bypass. Here's the dose titration. You have to start low and go up. It takes 4 weeks to get to 2 tabs twice a day. Cost is $220. All these guys are priced about the same right now. And I'm sure liraglutide, when it comes at 3 milligram dose, is going to be probably 3 times that. So the next one will be much more expensive. All these guys are priced about the same right now. And none of them are magic when it comes to weight loss. Not a fan. And this one I won't tell you about except to say, don't use this drug. This is Merck's new antiplatelet drug for acute coronary syndrome, post-MI patients, or peripheral vascular disease. And in their trials, it was added to Plavix plus aspirin. It's triple antiplatelet therapy for the patient. You got to use 3 different antiplatelet drugs together. They all have different mechanisms. That's what they did in their trials. And in the TRIP2 trials that they got it approved, if you had stroke, they stopped it because it increased bad outcomes. They died sooner. So it's contraindicated if you had a stroke. If you had peripheral vascular disease, there's no difference with triple versus dual. The only place it was better was post-MI, a little bit better, but it's un poquito. And I haven't talked to a single cardiologist, including a friend of mine, Dr. Steve Nissen, Cleveland Clinic. I was on a conference call and asked Steve about it. Why did the FDA approve this drug? He said, I'll never know. I would have never approved this drug based on the data. And it's going to cost you $300 a month to add to your Plavix and aspirin. And if you're on an anticoagulant, it's contraindicated. You can't use it. The bleeding risk goes through the roof. The number needed to harm for bleeds is 3 times lower than the number needed to treat for benefit. It's a 3-to-1 risk versus benefit if you look at bleeding. That's why I don't know anybody who's going to use the drug. I would not use Voripaxar. This is a drug I would not touch. And that's the last one. So what else can we answer for you? I know our time's up, but yes, sir.
If we have questions, if you can head up to the microphone, we have time for a few questions. And
just one quick question. Is there, other than convenience, an advantage of Victoza over Byetta?
Yes. Again, that study was part of the duration trials, and they compared Byetta and Bydureon to Victoza, and Byetta also lost when it came to weight loss and A1C reduction to Victoza. So the only one that didn't lose is the newest one, Trulicity, and it did lose on weight, but it didn't lose on A1C.
Is there any withdrawal symptoms with the sleeping medication?
Withdrawal symptoms. With Balsartan, in their clinical trials, there was not significant risk of rebound insomnia when they stopped the trial. So again, most of their trials were up to, they were short-term 26 weeks. One went out to 52 weeks, and when they stopped it, they did not see significant withdrawal.
Okay.
So there is limited data.
What about sedation with the other psychotropic medications, such as neuroleptics and or benzos?
They did not specifically report that, but you have daytime or hangover sedation the next day in a lot of patients, so it's got to be additive. So I would still be concerned about that. It is a CNS depressant by turning off your wakefulness. It's a different mechanism.
One more
So
question.
is that antihistaminic then? in
No,
some
it's
way?
not antihistaminic.
Okay.
No.
All right, thank you.
One more question, and then we're going to take a
In
break.
the clinical trials, I'm interested in whether there were seizures on Afrezza, Belsomna, or Contrave, and also were there suicides on Contrave?
Okay. In the clinical trials, there were some cases of seizure, and we do know that when you use higher doses of bupropion, 450 milligrams or lower, that lowers the seizure threshold. It's one of the reasons we had a problem getting that drug approved and sustained release. So the potential problem there. We also know that with naltrexone, if that patient is on an opioid, can't use the drug because it is going to cause withdrawal from the opioid, and you could get rebound or you'll get opioid withdrawal from that. We also know that naltrexone has been used to reduce the risk of alcohol intake for alcoholism, so theoretically that might be beneficial, but it wasn't looked at in the trials, but we do have data on naltrexone for that. Belsomra does not have seizure reported, and it does not appear to affect the seizure threshold because it's not a benzodiazepine. So we do have seizures when you withdraw some of the other mechanisms that we have for insomnia. This one's a little different, and we don't have any data suggesting that was seen in the trials, at least not that I have seen from that one. It's been looked at, I'm sure, but I haven't seen any suggestion of a link with that. Was there another one?
Well, were there any seizures on Afrezza?
Alfreza, I did not see anything there, but you would imagine if you lower your blood sugar, you have a significant hypoglycemic event, you could have a seizure from that. But it wouldn't be directly related to the drug. It'd be related to lowering your blood sugar too fast, too far. And this guy lowers blood sugar faster than any other way we can administer insulin except for IV. Sub-Q insulin doesn't work nearly as fast as this guy does. And you saw the peaks were twice as high with Afrezza as compared to a sub-Q dose of either Aspart or Lispro insulin. So we do have that as a potential concern.
But it doesn't last long.
No, it's short-lived. But it's still going to last an hour to an hour and a half.
So it's only for pre-meals.
You have to use it with your meal. Don't give it 15 to 30 minutes before you eat, because it's right there as soon as you give it. You're going to drop your blood sugar before you get that first bite of food. So I would recommend you use it probably ideally right after you've eaten, so you can guesstimate how many carbs you had and decide what your dose is rather than trying to anticipate it on the front end, because it's so fast acting. And again, we've never had a drug that works this fast as far as insulin. So
Wayne, thank you for your presentation. This is
Thank you.
great.